With marketplaces becoming more crowded, and pressures to control healthcare budgets ever increasing, regulators and payers must make rational decisions about the licensing of products and allocation of resources, by comparing their supporting evidence from both pivotal and non-pivotal clinical trials. However, in many instances, head-to-head trial data comparing different treatment options do not exist. This could be for a number of reasons. Trials designed to gain regulatory approval may only compare a treatment to placebo, or to a treatment considered to be standard of care at the time of designing the trial. The standard of care may change in different markets during the course of product development. The choice of relevant comparator may not be the same across different markets. As a result, indirect treatment comparisons are often required to provide evidence of the comparative efficacy of two or more treatments in the absence of head-to-head clinical trial data. Also, on a global level, regulatory and health technology assessment agencies require high-quality indirect treatment comparisons to support comparative clinical efficacy claims and submissions. Let us now consider the rationale and methodology for conducting an indirect treatment comparison in its simplest form. Imagine we want to compare two treatments, A and B. If no head-to-head trial data exists, then a direct comparison of clinical efficacy cannot be made. A simplistic approach to compare the two treatments would be to compare the A arm of one trial to the B arm of another trial. However, this is not appropriate as it does not preserve the randomization of patients within each trial. Patients in treatment arms A and B are from separate trials and were randomly selected from different populations. Therefore, any difference in efficacy may be due to the variability between populations, and not due to the treatments themselves. By ignoring the randomization within the trials, the results may be either reliable nor robust. However, if both treatments have been directly compared to the same treatment, say, treatment C, in separate clinical trials, then an indirect comparison of the relative clinical efficacy of A and B could be made, using C as a common comparator. Such an approach allows comparison while preserving the randomization of patients within each trial. However, reality is often more complex than the example that has been described. For example, what if head-to-head trial data were available between treatments A and B, and that C was also considered as a viable comparator? Here, pairwise comparisons could be made between the treatments using both direct, that is head-to-head, and indirect treatment comparisons. A mixed treatment comparison, or network meta-analysis, could be performed. This would combine all the available trial evidence, both direct and indirect, to estimate the effect of A, B, and C relative to each other. The principle of mixed treatment comparisons can be extended to more complicated situations, when numerous treatments are of interest, allowing comparison of all relevant treatments without the necessity for head-to-head trial data for each treatment comparison. We will now look at the factors that need to be considered when deciding whether to perform an indirect treatment comparison and some of the methodological principles. For indirect treatment comparisons to be reliable, methodology needs to be robust, and data needs to be of high quality. The analysis should include data from relevant trials identified by a well-conducted systematic literature review. Crucially, trials should only be included if they are comparable with respect to factors that may influence the assessment of clinical efficacy, for example patient demographics and treatment duration or dosage, and, as with meta-analyses, the quality of each individual trial must be assessed. The systematic review should be based on the PICO framework in order to ensure that all relevant studies are identified. As with systematic reviews and meta-analyses, indirect treatment comparisons must follow a pre-specified protocol and aim to answer a specific clinical question. Such an approach minimizes bias and heterogeneity. For example, if we are examining the effect of different interventions in a population of patients with severe rheumatoid arthritis, we would exclude trials looking at patients with mild forms of the disease. Similarly, if we are only interested in outcomes reported as ACR70 values, then we would not include trials where the outcomes were reported as DS28 scores. By only using high-quality trials in an indirect treatment comparison, you can help ensure that robust conclusions can be drawn from the analysis. Let's look at how indirect treatment comparisons can be used in a real-world setting, using the example of drug A, a pharmaceutical product for moderate to severe arthritis. When it was launched, drug A was not the first drug to market. There was little perception of unmet need among payers, and no head-to-head trial data compared drug A to its competitors. To demonstrate the relative clinical efficacy of drug A to payers, it was necessary for it to be compared to the available treatment options. In the absence of head-to-head trial data for all relevant comparators, a mixed treatment comparison was carried out. To do this, a systematic review of published trial results was conducted to identify relevant studies. Including those involving drug A, a total of 16 trials were identified, containing placebo-controlled data from approximately 9,500 patients. All studies met pre-specified selection criteria to ensure comparable patient populations and outcomes. For example, all patients had experienced inadequate response to DMARD therapy, and all trials reported outcomes expressed as ACR 20, ACR 50, and ACR 70. That is the proportion of patients achieving 20, 50, or 70% improvements in their symptoms. The relative clinical efficacy of drug A could be established by a mixed treatment comparison, because all trials included a comparator arm containing patients treated with traditional DMARDs plus placebo. The results of the mixed treatment comparison demonstrated that all treatments were associated with significantly improved outcomes compared to placebo. In all response categories, that is ACR 20, ACR 50, and ACR 70, drug A had the greatest response versus placebo. The data from the trials were also analyzed relative to drug A. It was demonstrated that the effect of drug A was similar to other treatments for ACR 20 and ACR 50 responses. However, for ACR 70, a higher clinical endpoint, and potentially more relevant to patients, drug A was associated with a significantly greater response than drug D and drug C. It may be the case that differences exist in factors that influence treatment response across the trials included in indirect treatment comparisons. In order to provide confidence in the findings, sensitivity analyses can be conducted to assess the robustness of the results. In one scenario, data from one trial was excluded from the analysis as the placebo group had an unusually high response rate that was attributed to the management of treatment-naive patients with methotrexate, a common first-line treatment for rheumatoid arthritis. In a second scenario, data from a different trial was excluded as the background treatment was sulfasalazine, which was not comparable to all other trials that used methotrexate. In all scenarios, the ACR 70 response was still significantly greater with drug A compared to drug D, highlighting the robustness of the mixed treatment comparison. As such, even though no head-to-head data were available, the mixed treatment comparison established the efficacy advantages of drug A over other existing treatment options. This demonstrates the value that indirect treatment comparisons can add when generating comparative clinical efficacy evidence to support market access activities for pharmaceutical products. Indirect treatment comparisons can be used to compare treatment efficacy when there is a lack of head-to-head trial data. We have examined the considerations that need to be made to ensure results are reliable. We have presented an example that demonstrates how indirect treatment comparisons have been used to support the pharmaceutical products.